Good evening, everyone. It's true pleasure to welcome you all to the 30th episode of Endocrine Talk Show, a milestone that reflects our shared commitment to continued learning and collaboration in the ever-evolving field of endocrinology. Over the past 29 episodes, we have had honor of being guided by none other than Dr. Subhankar Chaudhary, whose exceptional moderation, the clinical insight, and thought-provoking discussion have been the heartbeat of this series. He is currently director at Department of Diabetes and Endocrinology at Medica Super Specialty Hospital, Kolkata. In today's session, we are going to understand about the role of GLP in management of diabetes, obesity, and beyond that, what could be the uses of GLP-1 in real-world clinical practice. So, with this word, I hand over the session to Dr. Chaudhary and request him to introduce our faculty for today's program. Over to you, sir.
Thank you very much. Good evening, our friends from all across the country. It's a pleasure to interact with you all. This evening, we shall talk the length and breadth of GLP-1 agonists, which have sort of caught our imagination, and we are using it more and more in clinical practice. As always, and probably especially so this evening, we are blessed with a galaxy of faculty from across the country. We have Professor Anil Bansali, who is currently Director Guinea Health at Mohali, who was Head Department of Endocrinology at PGI MER Chandigarh with a huge publication number. We are also blessed to have with us this evening a very senior endocrinologist, Dr. Bipin Sethi. Can we have his slide as well? Who is associated with the care hospitals in Hyderabad. He also has hands-on experience with so many national and multinational clinical trials. We also have the current president of the Endocrine Society of India. He is director of endocrinology at Paras Hospital in Panchkula. He is none other than Lieutenant General Dr. Narendra Kotwal. And we also have with us this evening Dr. Tiven Marwa, who is director, consultant endocrinologist and diabetologist at maybe Dr. Marwa may pronounce it for me, La Bonio Diabetes, Thyroid and Endocrine Center at Ahmedabad. He has had obvious French influence, that has training and various accolades from France, from Paris. And so these are our four renowned faculty members for this evening. And we try and encourage all our audience to ask questions. You will not get possibly such a fine faculty at your fingertips. So please do put in your questions in the chat box. We shall try and address as many of them as possible within the allotted time. I've been told Dr. Kotwal has to leave a bit early by about 9, so we shall try to have his engagements complete before that. I am looking at the chat box, haven't seen any questions yet. So maybe I start the ball rolling with Dr. Kotwal. So we have been using GLP-1 agonists for a while, but possibly we've been using much more frequently the DPP-4 inhibitors for various reasons. Actually, GLP-1 agonists were introduced into the market earlier, a bit earlier than the first DPP-4 inhibitor. The first one was exenatide, Byetta. And the first DPP-4 inhibitor was sitagliptin, Januvia. So why, and the reason that the use of GLP-1 agonists is coming up is finding mention in various guidelines is because they are more efficacious than the DPP-4 inhibitors. So can I ask Dr. Kotwal, what are the reasons? Because DPP-4 inhibitors also work by increasing GLP-1 levels by inhibiting their breakdown. So why is this difference? Why are they more effective?
Thank you, sir, for that question. Firstly, GLPs as such have changed the therapeutic landscape of diabetes and now in obesity also. As, sir, your question regarding the difference between the GLP receptor agonist and DPP-4 inhibitor. As we know that DPP-4 inhibitor inhibits the enzyme DPP-4 and increase in GLP is around 1.5 to 2 times. Whereas GLP receptor agonists are as such, lot of GLP is there which is acting on the GLP receptor agonist. By the huge amount of GLP as such acting on the GLP receptor, the metabolic effects are much more as compared to DPP-4 inhibitor. In terms of, well, let us look at the glycemic reduction in terms of HbA1c. With DPP-4 inhibitor, it is just around 0.5 to maybe 1%, whereas with GLP receptor, depending on whether this is oral or injectable and which one is being used, whether this is mono or just double agonist, HbA1c reduction is to the tune of 1 to around 2.5%. As far as the weight reduction is concerned, weight reduction, whereas the DPP-4 inhibitors are weight neutral, whereas GLP receptor agonists lead to a lot of weight reduction. And other metabolic effects in terms of the LDL reduction is also much more with the GLP receptor agonists. Besides that, GLP receptor agonists have anti-atherogenic, anti-inflammatory, endothelial function, and direct action on the cardiac myocyte. Because of those action, GLP receptor, since GLP receptor agonist, that concentration is much more, these are more effective in terms of the all metabolic function, which translates into the MACE reduction much more around 32 to 26%, whether we see the leader trial, sustain 6 trial, a rewind trial, and so many trials are going on. So because of all these more concentration of GLP and GLP receptor agonists, these are more efficacious than DPP-4 inhibitors.
Right. So it's quite clear that in terms of efficacy, definitely the DPP-4 inhibitors lag behind the GLP-1 agonists. But one reason maybe we have been using DPP-4 inhibitors quite widely is because of the cost factor and also because they're very easy molecules to use, don't have to bother about side effects and so on. Now I come to Dr. I do find Dr. Bansali has joined, but maybe we allow him some time to settle down. Let's come to Dr. Bipin. We know that GLP-1 agonists may have so many different mechanisms of action. We do understand there's so many good things they do. So what are the most important amongst these mechanisms of action, and actually what translates into CV benefit? Dr. Sethi, please unmute. Yeah.
I think that's a question which begs an answer because, as Dr. Kotwal said, there are enough evidences with GLP-1 analogs in terms of MACE reduction by to the tune of 14 to 15%. Some of them are preferentially they have good effect on the endothelial function and they do decrease the inflammation. There was some controversy in the past whether the GLP-1 by itself or the fragments of GLP are responsible for these actions, but whatever the action may be, these drugs do not act immediately. They in fact take some time, and there is some evidence with liraglutide that the beneficial effects after 3 years are much more than that, 2 years, and then there's much more than that, 1 year. That means they have to be taken for a long period of time for them to show their effect, indicating that unlike SGLT2 inhibitor, which work through hemodynamic mechanisms, these drugs probably retard or regress the atherosclerotic process. There is also evidence in experimental animals that it influences ischemic That is, if animal is treated with GLP-1 and later subject to ischemia, the infarct size is smaller. So there are therefore many mechanisms in terms of endothelial improvement of endothelial function by improving nitrous oxide generation, direct action on the cardiac myocytes. They also decrease the sympathetic tone, they decrease oxidative stress, they also decrease the fibrosis. So there could be multiple ways in which they influence the process of vascular health and cardiac health, and also regrets and retard atherosclerosis. So this is some of the mechanism, but the exact mechanism as to whether this is the real way in which they act is not very clear. So there are multiple mechanisms.
Right.
One more important mechanism is weight loss. But weight loss produced by these drugs is far in excess of that produced by SGLT2 inhibitor. That might also explain the core factor in process of the kidney and cardiac disease as well as hepatic steatosis. So decrease in the weight probably is also a good contributor to this beneficial effects.
Right. So we have heard that there's multiple ways. Probably it's a sum total of all rather than any individual effect. I would just like to probe further. So when you talk of the anti-inflammatory effect, is it because of reduction of obesity, or is it a direct anti-inflammatory action?
Probably largely because of reduction in obesity. Inflammatory markers that have been studied with the earlier molecules as also with this molecule are showing that the interleukin-6 and various other markers of inflammation do come down in the sera obtained from people who are participating in these trials. So that is probably one of the mechanisms, but to say that that is the only mechanism may probably not be correct.
Right, right. And you also referred to anti-sympathetic action, did you?
Yes, there is decreased sympathetic tone by these molecules. So this would
but at the same time, these agents have been shown to increase the heart rate a little bit. And we use beta blockers for their beneficial action. One of the ways is to reduce the heart rate. So what is it, does it reduce sympathetic tone significantly?
No, it does reduce. People felt in the past that may be the reason they're not as effective in heart failure as might have been the case given their other properties. But I do not think that they do not decrease sympathetic. They do decrease sympathetic.
Right. So I hope Dr. Bansali is now well settled in his seat. Right. So can we ask you about? We are fortunate in a way that we have oral GLP-1 agonists. We have once a day GLP-1 agonists. We have once a week GLP-1 agonists. So how would you compare at least the oral ones? Because some individuals say, no, I don't want injection. I want only the oral one. So how does the oral currently available semaglutide Rybelsus compare with the injectable ones? Please unmute. Dr. Anil, please unmute. You're muted.
So oral, we have a reasonable in our experience with oral semaglutide, that is Rybelsus. And injectable semaglutide we don't have, but now the Wegovy is going to launch soon in our country also. So what the literature shows...
But we have already injectable dulaglutide once a week.
We have injectable dulaglutide. We had a very limited experience with that. Yes, Mounjaro now, the tirzepatide. Now we are getting enriching our experience with that also. So oral semaglutide, yes, it's a good alternative. Those who do not want injectables, that's the one. The side effect profile also remains the same, almost what it remains with injectable. But I think slightly better with injectables than the oral, because the daily side effect may be there. But eventually, even with the oral semaglutide, even with the daily intake, the side effect profile wanes away. The weight loss is lesser. The weight loss, which is usually found in most of the studies, is around, and even in our experience, it is around 3 to 5 kg. Yes, some people they have lost say around 10 kg plus, but they may be more outliers. The hemoglobin A1C reduction with the oral semaglutide is somewhere around 1% or 1.2%. While with the injectable semaglutide, it is something around 2% or even 1.8 to 2.2%. Weight loss is more this, and the side effect profile almost remain the same. The cost of injectable semaglutide certainly is higher, and it is going to be higher even with the injectable semaglutide, which is going to be lost. So that may be more. And I think the two things which have emerged now is the higher the dose, higher is the side effect. That's one. Higher the dose, higher is the weight reduction. That's two. And secondly, what we have also found is that oral semaglutide versus the injectable tirzepatide, those who already received either your liraglutide previously or the semaglutide previously, and if they are switched to the injectable tirzepatide, I think the response till the dose of 5 milligram is is not rewarding or is not increasing. So I think they do require higher doses because whatever the weight they have lost, so there is not a further much loss with the tirzepatide. We'll have a more discussion on this. If you switch, what happens to that? But I
Right.
think, yeah,
Yes. So what about the CV benefits?
yeah. For a semaglutide, we have gotten now CV benefits. Initial trial which was available because the data was not so robust because the number of the deaths required for that, so that was not there. So now I think that we have got the data available now about that. So semaglutide has got two things. One is that it has got an effect on the MACE and it has got an effect even on a heart failure. While as opposed to it, while it was not shown with your liraglutide. With the liraglutide, only MACE benefit was shown, that is around 13%, while there was no benefit in a heart failure or there is no significant benefit in. So, but
And yes, and
yeah.
the CV benefit has been shown even with oral semaglutide.
Even with oral, but it could not reach the significance. So because the number of deaths required for that was not there. So then they did the SOUL trial, and the SOUL
Yeah,
showed the benefit. The SOUL
yeah,
trial showed the benefit
yes,
that there is a
yes,
cardiovascular benefit even with the oral semaglutide and significant benefit. And it
right,
additionally it also showed even there is a benefit in heart failure,
right,
hospitalization. Heart.
right. So we'll come to Dr. Tivan Manwa, but before that, we have a few questions in a chat box. Uh, maybe Dr. Kotwal, please. So Dr. Jitendra Shah wants to know, can GLP-1 agonists and DPP-4 inhibitors be given simultaneously if we are using low dose of GLP-1 receptor agonist?
See, anything because mechanism of action is to be increase the GLP. So doesn't make scientific relevance to combine GLP receptor with DPP agonist. It is just like combining one sulfonylurea with another sulfonylurea. If at all once we are starting GLP receptor agonist, DPP-4 inhibitor have to be stopped. We don't have to give both the drugs simultaneously.
Okay.
Yeah, that.
Shubhakar, can I give a comment here?
Yes, yes,
Yes.
yes.
So I think Narendra pointed out rightly, but there is a one study by the Dr. Satish Garg from our own institute, and he gave one argument, and he showed there was a benefit. However, the DPP-4 inhibitor was combined with exenatide at that time, which was available in that. So that showed additional benefit or additional reduction in glucose profile. And there were two reasons which makes it slightly better in understanding. One is that you are giving a predominantly GLP-1. Semaglutide is GLP-1. However, if you use tirzepatide, it is both GLP-1 and GIP. By giving a DPP-4 inhibitor, you are increasing not only the concentration of a GLP-1, which is really not required in the presence of inject or in a GLP-1 you are already giving, but the rise in GIP may give an additional benefit in glycemic control, though it may not be significant. But another advantage which was discussed with that, if you raise the concentration of a GIP, then what it happens is that the GIP stimulates glucagon during the phase of hypoglycemia. So the hypoglycemic episodes may be less or may be better tolerable if in a scenario when you are using isolated GLP-1 analogs. But like certainly if you're using a terzipatide like, then certainly it is not. But it was just, but the benefit is very modest, but just for the understanding, even if you combine, scientifically it is not correct, but though it does not show any much benefit.
Yeah, so the bottom line is generally it is not recommended, right? So we come to Dr. Thiven. So we have already heard about tirzepatide. Dr. Bansali already mentioned about it. So it seems to be a wonder drug. Everyone is waiting for using it. It seems to cause more weight loss, more A1C lowering, and as Dr. Bansali mentioned that it's not just GLP-1 agonism, it's also GIP agonism, and possibly it's more a GIP agonist than a GLP-1 agonist. So, do we understand from our understanding of biology or physiology as why it should be more effective? Because it's also got a GIP agonistic action.
Yeah, thank you, Subhankar, and the organization for giving me this great opportunity to share the diet with stalwarts of India, Dr. Naren Kotwal, Dr. Anil, yourself, and also Dr. Bibin Sethi. Now, answering the question, yeah, it's very vital and important to understand. Dr. Anil Bansali already elucidated about the role of GLP while discussing combined DP4 inhibitor plus GLP-1. Well, this molecule, tirzepatide, it contains a GLP-1 agonist as well as GIP agonist. We have understood the incretin pathways to manage, euglycemia in normal healthy person as well as diabetic persons in last 3 decades. But first 2 decades were dominated by GLP-1. Its impact on, controlling diabetes, blood sugar, and keeping glucose homeostasis in healthy person and eventually diabetic patient. But the role of GIP was sort of highlighted in last 5, 7 years only, although it was known that DP4 inhibitor engage both GLP-1 and to some extent GIP, and there can be some anti-hypoglycemic effect of GIP. But using it as a molecule to treat diabetes has been, explored by this organization, Eli Lilly, and then it was formulated, and then that Monjaro came, tirzepatide. Uh, Now, coming to the theory, the incretin mechanism, there is definitely role of GLP-1, but there is a 50 to 70% role of GIP in normal healthy person. So whatever incretin effect we see in a normal healthy person, it comes 50 to 70% comes through GIP. So using GIP-1 agonist is a very smart move. And secondly, this molecule is smarter than GLP-1. If you see the mechanism of action, it works on alpha cells, beta cells in pancreas, it works on adipocytes, it also works on hypothalamus. So it's the molecule which works for both on alpha cell and beta cells, and it works as and when we want. It secretes insulin in glucose-dependent manner by stimulating beta cells, and it also improves glucagon where there is a hypoglycemia, again in a glucose-dependent manner. So this is how it reduces.
Dr. Madhwa, that I do understand that may explain the better A1C lowering. What about weight loss? Why should
Yes,
GIP agonism
yeah, it has got
improve weight
also
loss?
effect on
Does it have
hypothalamus.
is
Yes.
that a significant effect on the
Yes,
hypothalamus?
yes, definitely. It reduces appetite. It reduces the craving for certain food, and particularly the sugar items and fatty foods, and it improves satiety. So this is another way how it works to reduce appetite and eventually weight gain and obesity. And third
Okay.
thing, of course, it works on adipocytes. It increases fat cell and also free fatty acid goes into the fats when there is increase in fats, and when it is needed, it also improves the lipolysis. So it's a very smart molecule, and with different mechanism of action, it helps reduce weight.
Can I also share uh, that the area to me looks quite confusing in the sense today we have got evidence for a combined GLP-1 agonism and GIP antagonism, a combined peptide and monoclonal antibody conjugate, which is also effective in weight loss. So I still am not very clear, but we have the evidence before us that it works. It causes significant amount of weight loss. So can we come back to Dr. Kotwal? So what do we expect in terms of weight loss? So my patient, 120 kilos, height 170 centimeters, ideal body weight, let's say 72 kilos. So when we start GLP-1, so what realistic expectations can this individual have? Come down to 72?
So weight reduction with the GLP receptor agonist depends upon the which agonist we are using. Like initially,
Okay, you're using the most effective.
yes, most effective. Like it all depends upon the what is the weight of the individual. Higher the weight, more is the weight loss as such. With the tirzepatide weight loss, which has been seen with the different doses, like with the 5, 10, and 15 milligram, and in a non-diabetic, with the 5 milligram, it was around 16%. With the 10 milligram, it was around 21.4%. And with the 15 milligram, it was around 22.5%. Whereas within the diabetics, that weight reduction is about 4 to 8% lesser, around 15.5%. Having said that, it is not that everybody is going to lose weight. Initial weight loss is around 2 to 4%, occurs around 2 to 4 weeks, then around 5 to 10% around 3 months, and after 6 to 12 months, there is the plateauing is there. All person, as I said, don't lose weight. There's a lot of heterogeneity. Around 10% of the non-responders, and around 10 to 20% will be super responders, which they can lose weight around more than 25% also. So which are the person who are going to lose the weight? We don't have biomarker as yet to find out who is going to lose weight. But having said that, higher the weight, more is the weight loss with this GLP receptor agonists.
This should be. Yes, Anil.
Yes, Arya, Pali, you can finish and then.
No. What I'm suggesting is this: the higher the weight, the greater the weight loss is the absolute weight loss. But if you talk of the percentage weight loss, yes, possibly it does not differ a whole lot. If you're talking of percent weight loss,
around 70% of the individual had lost more than 25% of the weight.
Yes.
I'll just make 2 comments here. One is that almost 15 to 20% of the patients, they do not lose weight. Whether even with the tirzepatide, they have shown that all do not lose weight. But the glycemic efficacy is almost in 100% of patients. So the hemoglobin A1C reduction, of course, often to the same magnitude, but it does happen almost in every patient. But the weight reduction of 15 to 20% of patients, they don't lose weight. Secondly, the diabetics are more resistant to weight loss as opposed to obese people.
Yeah, he mentioned, yes.
Yeah. So that's a 13% versus 22% you do a weight reduction. Third is higher the dose, greater is the weight reduction. And after some time plateau, and once you discontinue, you again regain weight, though not the rebound, but you again gain the weight within a period of 6 months to 12 months.
Right. So I'll bring another important point before Dr. Kotwal, because he has to leave early. So maybe we'll bombard him with more questions. We know this weight loss, we would all imagine that it's all only fat loss, but in reality, it's not so. There is loss of lean body mass as well. There's loss of muscle. So what should we do to prevent this loss? Clearly, type 2 diabetes, especially in our countries, associated with sarcopenia. So we would want our patients to lose more muscle. So what do we do?
So that is an excellent practical question. Now, with all these studies, what has been shown to us that there's a weight loss, there's a more fat loss, but we know there is a lean muscle mass also, the loss also occurs. To prevent the lean muscle mass, patients should continue with their resistance exercises and high protein diet. Now we know that the study which has come, in fact, despite all this, there is still lean body mass, and which is the actual reality. That is why in the BELIEVE study they have used the bigarumab, which has shown prevented the further lean muscle loss. So those studies are coming where they are trying to prevent the lean muscle mass with all these molecules. To say that lean muscle mass doesn't occur, it does occur. So to prevent that, I think in the practical sense, we should tell our patients to continue their resistance exercise and to increase their protein intake until we have the drug which increases the lean muscle mass along with the fat muscle loss.
Right. I would really thank our audience across the country for showing so much of interest, and they have put in so many questions in the chat box. Let's digress a little bit and take on the questions as many as we can. So a very important question, practical one, Dr. Rathore. How long should we continue GLP-1 receptor agonist in obesity? Do obesity return once we stop it? Dr. Bansali has mentioned. Dr. Bipin Sethi, would you like to take this?
I think a drug can work only as long as it is taken. But if you look at this study which you were referring to, there was no complete restoration to the baseline. There was still some weight loss, which might have been due to the changes in the dietary patterns or the behavior of the patient. It's true that there is improvement followed by weight regain, but I guess there's something more that is there, and people have found that in real world evidences, sometimes the weight loss is less, sometimes the weight loss is more than that of the randomized control trial. So I guess we have to continue this medication, and that commitment the patient should have rather than thinking that it's a small time. So I think that's important. And I completely agree with you, sir, that GIP antagonism is as effective. The Maritide study which you were referring to has shown that this does help. So whether the GIP agonism after a while down-regulate the receptors, and Bansali is the best person to talk about down-regulation, and maybe leads to overexpression of the GLP-1 molecule actions is not very clear. And most of the people say that they do not know, but it's very clear that GIP in and by itself has multiple roles to play, and GIP antagonism is definitely reducing weight of individuals, as the Amgen study with Maritide has shown.
Right. So we come down to practical questions provided by our audience. Dr. Shah wants to know from Dr. Tivin Marwa how to titrate dose of oral semaglutide. Very practical question. So what should we do? How should we start?
Well, I was fortunate to participate in this just concluded SOUL trial, and so we had 25 patients, which lasted for about 5 to 6 years, and the classical recommendation 3 milligram, 6 milligram, 14 milligram, etc. The results are already out, and so most of the patients, Indian patients, they were fine with 6 milligram, 14 milligram or 7 milligram rather. 14 milligrams, they have issues, side effects, etc. And the biggest problem with this molecule, the way it has to be taken. It's very cumbersome. The amount of empty stomach. Many patients are taking other medications, so it's very difficult to counsel and adjust all those things. Having said this, yes, since it was oral, it was well acceptable, but the reduction of A1C was around 1%, and weight loss was not so great. Many of the patients did almost 30% didn't lose a kilogram. So I would say it can be a good anti-diabetic medication, having different mechanism of actions vis-a-vis other oral anti-diabetic medicine. But as far as weight loss is concerned, it's not so effective.
Yes, but then how do you titrate the dose was what Dr. Rasa wanted to know.
We start with 3 milligram, and most of the patients we need to increase up to 7 milligram, and then
when do you increase?
After a month or so, and most of the patients, they tolerate it very well. I have not any occasion to discontinue medication, even if they reach up to 14 milligram. Couple of patients, they require to de-escalate medication to 7 milligram.
So after a month, what do you do?
Yes.
7 milligram.
Yes, yeah.
And
3
then,
milligram doesn't work, then we increase up to 7 milligram. And then some of the patients we continued even up to 2 or 3 months before increasing to 14 milligram. Although the guidelines say that you need to increase after a month to 14 milligram, that was also in the protocol. But we continued for about 2 to 3 months if there was a effect on weight and as well as blood glycemia. So
okay,
although there are recommendations, but we can adjust as per the response from the patient rather than just a thumb rule that every month you increase from 3 to 7 and then 7 to 14 and then maintain. It is not
right.
required.
Right. And we also, I think, need to remember that maybe at a 3 milligram dose, the efficacy is not great. So if the patient starts checking or expecting in the next 7 days, there'll be significant improvement, maybe in the glucose readings, they would be disappointed. So we have to counsel our patients when we start on these sorts of medicines. So now we come to Dr. Bipin Chetty. And this is a question that Dr. Chaurasia has put. I don't know where the doctor is located. So, is there any difference in efficacy between generic versus branded liraglutide? What is your experience? Maybe you will say you only use branded, you don't use generic, so you don't have any experience.
I think it's not that way. I will not evade the question that way, but what I would say is that we would not in a clinic have the possibility of changing one patient from one preparation to another. So that question is a little bit difficult to answer because the regulatory authorities have looked at the data of the trial that was done with the innovator and the biosimilar in terms of HbA1c reduction, fasting, postprandial glucose reduction, side effects, antibody. So one can confidently use these molecules expecting the same kind of that the innovator molecule did. Now that the innovator molecule for that particular drug is not available, so this kind of question cannot be answered whether it is as effective or not. So we have to go by the data submitted to the regulator and feel safe with that. Now that we have got injectable semaglutide available to us just available to us 3-4 days ago. 3-4 days ago. Tomorrow there will be another the generic one. So unless we say that person was on say Innovata, then shifted to this drug and went back to Innovata, there was no difference. One cannot say conclusively, but whatever little evidence we have with the biosimilars, the result is good. And we are able to use more of it now because of this reduction in the price. This happened to everything from DP4 inhibitor, transthyretin inhibitors to the molecules that we have like liraglutide now. So efficacy is there. Obviously, one cannot do a CV outcome study with these molecules.
Right. So there's a question from Dr. Gupta, and maybe Dr. Tivan, you could take it. When to add GLP-1 RA in non-obese diabetes? Should we consider it ahead of insulin, considering side effects associated with GLP-1 RAs? So in non-obese diabetes, type 2 diabetes, do you use GLP-1 receptor analogs?
Well, through its distinct mechanism of action, theoretically one can use, but we are having other molecules, and because of the cost, there is very limited experience in non-obese type 2 diabetic patients for GLP-1 agonist therapy, either oral or injectable. Although there are also studies coming for type 1 diabetes using GLP-1 agonist in normal weight type 1 diabetes. Of course, it will work also in obese type 1 diabetes, but this experience is quite limited. I would just ask Dr. Kotwal or Dr. Bansali to who have their comments if they are having experience in obese.
So, yeah, Dr. Subhankar. So I think the question was that a non-obese individual, whether you would like to use the GLP-1 agonistic analogs. So we use particularly in patients who have got a ASCVD and SGLT2 inhibitors are usually if they are not tolerated by them. So that's one indication where you surely use this. And though our experience, we have used even in a non-obese people, they don't lose much weight because the baseline weight is low. So the weight loss is not a thing there, but getting a good glycemic control and having a known cardiac benefits and known glycemic benefits, I think that's more important. So that's the one, particularly when SGLT2 are intolerable and person is non-obese and having a HCVD. In that scenario, I think that makes one very considerate indications to use this class of compounds.
Okay, so we come back to Dr. Kotwal. So this is a question from Dr. Singh. What about thyroid carcinoma risk with GLP-1 RAs?
Yeah, theoretically, the risk of GLP receptor is on the medullary thyroid carcinoma, basically on calcitonin increases the calcitonin. Or some in the studies, animal studies, it has been shown to the increase. But having said that, if only somebody has a history of medullary thyroid carcinoma, or if there's a family history or past history of this thing, only then one should not give it. Whereas other thyroid nodules are concerned, it doesn't increase as such, the nodules as such. But basically for MTC, there's a contraindication.
Because possibly normal thyroid parafollicular cells, C cells, they do not have much of
Yes.
GLP-1 receptors.
Right.
But if you come to medullary carcinoma, then there are greater expression of the GLP. Right. So, but do we need to monitor calcitonin levels when we administer?
As of now, there's no recommendation that calcitonin levels should be done before starting
Right.
GLP.
Right. Good. So next question. Interesting one. Dr. Divya Pandey, GLP-1 RA as an agent to reverse diabetes in moderately obese pre-diabetes. What are your thoughts, Dr. Bipin Shetty?
Well, I think if you look at the approval for GLP-1 analogs for treatment of pre-diabetes, it does not exist.
No.
However, there will be obese individuals for whom you are going to use these molecules who would be having different ranges of dysglycemia, normoglycemia, pre-diabetes, and diabetes. And since weight and in those individuals, and weight is the only driving factor, then likelihood that this person will become normoglycemic after the usage of medication and go into remission is possible. There's an interesting term now. People say diabetic remission without medications. And now another term has come, diabetic remission with medications. So with GLP-1, like everyone is, if somebody is obese and loses the kind of weight that Professor Kotwal, Dr. Bansari, everybody else mentioned, then naturally the likelihood of this person becoming normoglycemic is definitely there. And as long as this continued and as long as the person's beta cells remain competent, he may remain normal. So many people have argued now as to why can't we say remission with GLP-1 analog therapy. So while you would not give it for treatment of diabetes, remission or otherwise normoglycemia attainment is very much possible with the weight loss that we have. And the typical example is GDM. Whenever you have GDM, the person loses weight and person also has the hormone that's causing insulin gone. The person becomes normoglycemic in the next pregnancy. So I guess your question is quite valid, but do not give the treatment for pre-diabetes, say that the drug is being given for obesity, because then there is a real approval for that.
I think.
Yes.
Yeah, so my comment is yes. It is not for pre-diabetes, but it is basically for the remission of a disease. There are no data available. Only one abstract has been published from our department. From PGI, we have published one data on oral semaglutide, and is a remission of a disease. So after discontinuation and follow for a period of 1.5 years, only half of the people could maintain the remission. Otherwise, there is no data available for the remission of the diabetes with that. But theoretically, it is likely to happen because most of the available data for the remission of a disease is with the lifestyle modification. So whether you from a direct study and later on you have a look ahead study. So whatever the studies, they have all been based on lifestyle modification. From a drug or what we say pharmacological remission, and then the withdrawal of the drug and leading to remission of a disease, at least no data with any GLP-1 analogs are available, except that one extract which has not been published.
Yeah. So, Dr. Kotwal, you have first to tackle the GI side effects of GLP-1 receptor analogs. What are they and how do we tackle them? And then we have another interesting question from Dr. Ashok Agarwal. Please do remind me, I shouldn't forget to address that to you. Yeah, please go ahead. GI side effects.
Regarding the GI side effects, firstly, whenever we are initiating, we have to educate our patient and we have to tell them that GI side effects are going to be there. Like nausea is the most predominant, around 30 to 50% of the individual have nausea. Then nausea, vomiting, constipation, diarrhea, flatulence, reflux, fullness. All this because of the physiological effects of the drug, which it decreases the gastric motility, intestinal motility, acting on the area postrema, which increases the nausea. So we have to educate our patient that this will occur, but over a period of time, it will settle down. So they have to keep on persisting. We have to start low and go slow in escalating the dose. Whenever there's a dose escalation is there, these problems can occur. Having said that, we must tell our patient to take small amount of food to avoid fatty stuff and keep their hydration. Hydration should be good. Despite all this, some of the patients may still have the side effects like nausea, vomiting may still percent, and 10 to 5 to 10% patient they don't tolerate. They may have to stop these drugs, but we have to educate our patient that these are the temporary side effects, and over a period of time, over a period of 1 to 2 months, these will subside. Some of the patients may require medication for that. For vomiting, we may have to give sometimes for nausea, domperidone or ondansetron. For constipation, patient may require PEG or lactulose or high fiber diet. And for a reflux, we may have to give PPI inhibitors. But most important thing is to tell our patient to small frequent feeds, and when they are not hungry, not to eat too much of the.
What about diarrhea as a side effect? And I'm told by various practitioners that with tirzepatide, diarrhea is a major effect. So, which I have not yet felt, but your
So as far
feedback and then maybe from the others as well.
as per the evidence, around 10 to 20% of the individuals may have diarrhea, which subsided in due course of time. I have used this tirzepatide in very few patients, but this problem I've not seen. I've seen more of the nausea, vomiting problems, but diarrhea I've not come across.
Right. Others would, Dr. Shetty, would you like to comment?
Different people behave differently.
Yes.
I have a family of 3 people. The brother has vomiting, the sister has constipation, and the other sister has got diarrhea. So they are
on GLP-1. On GLP-1.
On tirzepatide.
Tirzepatide, okay.
They have taken it for obesity, and 3 of them came with 3 different side effects. Because they are quite a bit overweight, they are willing to continue. But as to who is going to get which side effect is very difficult to understand. And as to why some people don't get any side effect also is difficult to understand. But yes, diarrhea is a known side effect and does happen. And maybe different people report it differently. I agree with Professor Kotwal that the side effect profile is more of nausea, vomiting, bloating. And the lower GI side effects are lesser in number, but definitely known.
Yeah, Dr. Bansal, you wanted to say something.
I think 2 things. One, because the mechanism of most of the GI symptom is basically central. So the ondansetron is more effective than your pantoprazole and domperidone. And sometimes the amla candy have also been used, because they have been shown to be more effective as a part of the therapeutic phenomenon.
Right.
Yeah, amla candies. And for a diarrhea, yes, as Google rightly pointed out, anyone can have any side effects. And the side effects are more possibly known in those because the crossing of the drug to the blood-brain barrier. It is basically the glycosylation of the blood-brain barrier is there. That's why the GLP-1 is not able to cross. If it crosses at a higher concentration, then the side effect profile is nil. So possibly those who have a very long duration of a disease, they may have a lesser symptoms. That I think I do not have a support for the literature. The literature also mentions about the GLP-1 and GIP is you require a 4-fold higher concentration of a GLP-1 to have an effect on the hypothalamic centers to reduce the appetite and increase the satiety. So there are some issues in that.
Right. So I think Dr. Narendra Kotwal has other commitments, so had to leave. So maybe we'll address this question of Dr. Ashok Agarwal to Dr. Tivan Marwa. So because already Dr. Kotwal talked about sarcopenia as a side effect of this class of drugs. So what Dr. Agarwal suggests is, though sarcopenia is a distinct side effect of these drugs, there are animal studies which have shown that there is 15 to 20% reduction in left ventricular mass. Is there any human data with GLP-1 receptor analogs causing cardiomyopathy in patients using this drug? Dr. Tiven Marwa, and then maybe Dr. Bansali.
To the best of my knowledge, there are no data which suggests that this drug causes cardiomyopathy or this
Yeah,
drug causes other, aggravation of heart failure. As we know, but through mechanism of action, it is beneficial. I mean, I have not come across any
yeah,
literature
I'm
that
not. Yeah, Anil, do you know of any?
Yeah. So, yes, animal data show there's a decrease in left ventricular mass. And even the studies on the patients with heart failure with preserved ejection fraction, they have shown that there is a reduction in left ventricular mass. But there is no trial available that which has been particularly done in patients with cardiomyopathy. It was just as a sub-hoc analysis. We have shown there is a decrease in left ventricular mass in the people, those who were heart failure with preserved ejection fraction.
Right. So we fall back on Dr. Bipin Sethi with this patient of mine who is got type 2 diabetes of long duration, is obese, BMI 34, and about 10 years back he had something like alcohol induced acute pancreatitis, and he now swears that he has given up alcohol. So does his family members corroborate? Yes, he has given up. Now his A1C is 8.5, he's obese. Now can I start him on GLP-1 therapy?
Well, past history of pancreatitis is a relative contraindication. First, one has to establish that is there no other drug that this patient can take. For instance, this patient can also be managed by giving an SGLT2 inhibitor. But assuming that he's already on SGLT2 inhibitor and he still continues to have the glycemia of the type and kind that you have, we have exhausted all the options, and the choice is between an injectable insulin and a GLP-1 analog. So one can give GLP-1 analogs if the reason for pancreatitis has ameliorated. For instance, somebody had a gallstone disease, your patient had alcohol,
Yeah.
and that has been taken care of, or this patient is no longer having the hypertriglyceridemia of the sort that he had with alcohol, or his hypertension has been taken care of. So if the patient is stabilized, has not had any recurrent evidences of pancreatitis, does not have a pancreatic ductal caliculi, this patient, I would certainly like to get an ultrasound abdomen to see whether he has got gallstone disease. And he is likely to benefit, and he's explained that there is a remote possibility of pancreatitis occurring, which will be diagnosed by his symptomatology more than by serology, or then I think there is a place one can start it, but one should make it clear that this sort is not recurrent. The factors that can cause pancreatitis are no longer obtaining. There is no gallstone disease, there are no ductal caliculi. Hypertriglyceridemia has been managed, and she does not have any drugs that can precipitate pancreatitis. And with that provision, we can give. We have one patient who is on tirzepatide. He had gallstone disease 3 years ago. He was taken care of. He has had no attacks. His pancreatic ducts are cleaning, and he did not have any stone CBD. He also asked this very question, and we said that you can take it. And he's been on it for now 3 months from the time that this can be available in the market. He has lost about 8 kg. He's quite happy about it. But I think this should be a patient-to-patient decision, and the patient should be aware that there might be a remote possibility of that thing coming back again. So I would not be the full treatment, but I'll exhaust all therapeutic options, and when it is between this and insulin, probably I might give him a trial of this, specifically since he's overweight and otherwise
Right.
convinced.
Right. So we have talked about various good effects as well as adverse effects of this class of drugs. So one thing that we haven't discussed, Dr. Marwa, is about the retina. So do we need to screen the retina before prescribing this class of drugs? Or during treatment, we need to ask them anything beyond what we would normally do for any patient with type 2 diabetes?
I think this it's a common wisdom that all diabetic patients who are, a diabetologist sees, he should undergo retina check. Now, coming specifically, if you are starting GLP-1 receptor agonist, there are studies which have shown that sustain 6 and that there is an increased chances of diabetic retinopathy in patients who are on GLP-1 agonist versus placebo. And uh, but these studies were not so standardized, so we are not very sure that
Agreed.
whether these drugs were responsible. But having said this, it is prudent to do retina check, and there are patients who are more vulnerable, like the duration of diabetes is more, HbA1c is very high. These patients are more likely to have diabetic retinopathy. So it is better to check retina, although there are no guidelines which suggest that every patient who undergoes or will be prescribed GLP-1 has to be investigated. The common clinical wisdom would tell us that we should do this is a window of opportunity. If the retina is not checking last 3-4 months.
So that's fine. So the patient comes back with mild non-proliferative retinopathy. So should we desist from using GLP-1 receptor agonist?
Well, if it is non-proliferating retinopathy, and if there are other reasons to start GLP-1 agonist, one can start and then one can review after 2 or 3 months. But if there is vision threatening like macular edema or proliferative diabetic retinopathy, one should not start.
Right, Dr. Sethi wants to interject. Yes.
Not really. What I wanted to say was that this issue is come up recently, and there is evidence at least being looked at in the term of focus study, which is being done with injectable semaglutide, and that study is almost now into 4 or 4.5 years of its inception. The data safety monitoring committee keeps on looking at worsening of retinopathy because that is the reason why this study has been done and was commenced to begin with. They have not sent any signal. And the data that we are seeing comes from a single center, single observer. And in view of the fact that I can say millions of patients have used it, and in fact, people have been wanting to use this drug, striving to get it. I don't think that this is a definite association in sustained 6. They said that rapid progression of pre-existing retinopathy might have happened because of a very good glycemic control, which everybody alluded to. So I think the question is still open, and there are people who are asking at the first that these Google wala and computer walas, they come first saying that give me this medicine, and they say, do you think that AI1 is going to happen to me? So I guess this has to be handled in a manner and fashion that one has an equipoise. But as far as a randomized controlled trial, which is already in progress, is concerned, we don't have any evidence as yet. There are people who say that there are receptors of GLP in the retina and might produce a worsening of retinopathy, unlike SGLT inhibitors, which or some people say protective. But I think the final word on this is not there. If a patient asks me that, is there a case report of anything, one can say, okay, yes. But is it safe for most patients? Then the answer probably is that we are awaiting the results of a focused study to make that particular judgment. But I think this should be discussed, as Professor Shivankar said. We should tell patients that this might be a possibility, just like we tell about the GI side effects. But I think the incidence must be extremely low, and this is being looked at in a more scientific manner.
Right. So, yes, Dr. Ansari.
But yes, it is right that we don't have a data with the new results, but the leader trial for the liraglutide, that showed there was a worsening of the proliferative diabetic retinopathy and moderate to severe non-proliferative diabetic retinopathy, and possibly it was related to rapid glycemic control with the powerful agents. So similarly, newer analogs are more powerful, but of course, no signals are available like that. But still, those who are having a proliferative diabetic retinopathy, we should be cautious and more regularly monitor.
Right. So, can we are trying to gradually wind up, maybe. Dr. Shetty, can we once again ask you about a patient is on weekly dulaglutide, now finds it cost is too much, and now heard about branded generic forms of liraglutide. So, what would be your suggestion? Would suggest to you, can I shift to this lower cost medicine? So, what should we suggest to them?
I think we have to know why the GLP-1 analog was started in this patient. Was it started for primary prevention or secondary prevention? Because there's no data with liraglutide on primary prevention, but assuming that it was started for glycemic control or for secondary prevention, yes, we will shift. Then we'll find out two things. A, is the patient already on liraglutide, or is the patient off liraglutide? If the patient is on liraglutide, we can safely go on to 1.2 milligram dose because he's already tolerating and he's accepted the standard dose of liraglutide. If, however, he stopped the treatment, we have to reinitiate him on another GLP-1 analog, which in this case is generic liraglutide. Then we start with 0.6 milligrams and then uptitrate it to 1.2 milligrams. So I think it is certainly possible to shift these people from one molecule to another, and this is bound to happen. If there is a price crash, say for semaglutide injectable now, many of our patients on tirzepatide would definitely like to go to semaglutide because there is evidence for that in kidney disease, in heart disease, obesity, hypertension, peripheral arterial disease, maybe SLD. Somebody wants to shift, then I think the consideration always is what was the indication, B, what is the current dose, and what is the acceptability. And certainly for cost reasons, we can certainly give this because both these molecules, as it has been noticed and commented earlier, they have had a CV outcome data, and both of them had it positive for secondary prevention.
Right. And what about someone on oral semaglutide now wishes to change to tirzepatide because that seems to be much more effective? Dr. Bansali?
Yeah. So, already has been on semaglutide and now we want to switch to tirzepatide. I think the two main reasons may be there. One is the weight loss may not be sufficient. So usually we do expect around 10% of weight loss. If it has not happened, I think that it makes a case to switch one. And secondly, still we are struggling to achieve the target hemoglobin level C below 7. So I think there are two ways when we like to switch. Or sometimes I think the side effect profile may be similar with them. So that may not be the reason that with a tirzepatide you may have a lesser side effect as opposed to the semaglutide. So we can have a switch, but the doses. If someone is already on a 7 to 14 milligram, I think the best is with the tirzepatide, start with a 2.5 milligram and gradually build up to 5, 7.5, and even up to go up to 10 milligram. But I think the two things which are basically including, one is the cost after the 5 milligram, and secondly, patient does not experience or patient does experience hardly any weight loss up to a dose of 5 milligram. So I think the two things which are facing the challenge in the clinical scenario, one is that the doses required to really lose the weight are higher, and those who have been previously exposed to semaglutide or even the liraglutide, even generic liraglutide, and have lost some weight, I think they are also not able to lose much weight after the use of after the switch to tirzepatide.
Right. So what you suggest is after they have already lost weight, they may not expect to lose additional another 15% on tirzepatide. That's understandable.
Unless you do a really higher doses. So we have used up to 7.5 milligram in few patients, but after that, either the cost precludes them not to use, or the side effect profile does not allow to continue. So our data is limited to this dose, only 7.5 up to. But those who have already lost weight with these class of drugs, that's why I think later on I found even the Lilly's recommended, the company also recommends the baseline weight should be counted, the what they had once with the prior exposure of the GLP-1 rather than the prior exposure to trazepatine.
Right. So we still are in our chat box, the questions that are posted. Dr. Raj Datta, which is better and safer to combine with GLP-1 analog, OHA or insulin? Dr. Tivan Marwa?
Well, I think both are having very distinct roles. OHAs can be used in certain patients, and which OHAs we are talking, that is also important. Of course, this patient must be on metformin and sulfonylurea and SGLT2 inhibitor, and one can definitely use GLP-1 agonist. But if person is having significant insulinopenia, then combining insulin and GLP-1 agonist along with metformin can be a good strategy. So it will all depend on patient to patient rather than a generalized statement.
I think that must be the view of the other panelists as well. So we have one question from Dr. Keshav. Recent study reported that only 8% continued GLP-1 analogs at 3 years. What could be the possible reason beyond cost? Is it due to GI side effects or general assumption? I don't know. Should we stop once obesity is controlled? So whoever, Dr. Pansali? Dr. Sethi, yes.
Yeah, I think this is quite well known that people do not continue it even in areas where the drug is largely or partially reimbursed. It might be because, as you said, not the cost constraint, but because undue expectations from the molecule, persistence of side effects. Because when you are in a trial, you are goaded and you are cajoled by your co-investigator or by the study nurse that, oh, please take it, it's only for another 1.5 years. And so whatever it is, so the patients, they lose interest and they do not take this. And this can happen with specifically when they are told that this drug is being given to you for weight reduction. For height and weight, people's expectations in terms of increments of height and decrement of weight are quite much more than what can be done by the molecule. This happens with growth hormone. This can happen also with these molecules. So I think disenchantment by the results, some side effects, and also maybe the need to take daily or once a week injections might be some of the reasons for this. But I think this is an area which is being actively studied as to why people are discontinuing this drug despite whatever they have been told. But I guess this has never been studied as to whether patient with ASCVD discontinued or not. I don't know whether with MSL anyway, data is coming up now. So if the reason was weight loss, people might discontinue. If the reason was an indication for, let's say, ASCVD or at risk for ASCVD, my own feeling is that they might be continuing this molecule. But I confess that even in literature, I was searching, and we did ask people as to why people discontinue, and they throw away some kind of answers or excuses. But I don't think it is 8%. Most of the studies at 2 years have shown between 47 to 60%. Some studies say that oral preparations are acceptable more. Some people say no, the weekly injections are more acceptable to the patient, but there is a lot of attrition. And how and why it didn't happen in the trials, I have already told you the reasons that patients are told this is something which is very important. And most of these are outcome trials, and people would probably continue. But the data in real world studies is extremely different. It's difficult and to retain people on this molecule.
Yeah, and I think part of the issue lies, and you correctly pointed that out, is how we counsel our patients. What are the expectations out of it? That also determines whether patient continues on it. And so we've come down to the yes.
I think it is the undue expectations that the patients are having regarding the weight loss. I think that will be one of the reasons that really disenchantment to the patient not to use continuously. However, some people have shifted to microdosing. They are using a smaller dosage of the GLP-1 analogs to continue the same and possibly maintaining the weight. And discontinuation is associated with the rebound weight because there's a plateau even you use the same dose for a long time. So there is
Yeah.
also, yeah. So that's why the people, they usually discontinue.
Right. So we come to the final question. This is from Dr. Modi to Dr. Bansali. Tirzepatide versus semaglutide, very simple one. Which one is better? And I would maybe just extend the question and ask Dr. Bansali. So someone has been started on Monjaro now, and after a year,
Okay.
maybe
So
branded generic versions of semaglutide injectable will be available,
that is within
which
26.
and then they have cheaper versions,
Yeah.
hopefully, compared to Monjaro. So should they then be switching over to Monjaro?
Yeah. So I
To
think,
to to
so I
to
think there is
injectable
head-to-head
semaglutide.
comparison, head-to-head comparison between the semaglutide and the tirzepatide. And that showed the superiority of the tirzepatide regarding weight loss as opposed to the semaglutide. However, there is a one more study later on published by the Novo Nordisk, and that again showed that if you increase the dose of the semaglutide from a 2.4 or slightly higher dose, what the dose usually used, then it showed the similar weight loss associated with that. The side effect profile, so both are, at least if you use the equivalent doses, then the weight loss is not different in the two scenarios. Semaglutide, we have got a lot of data on cardiovascular outcome, and we have got a data on a renal outcome flow trial. For a tirzepatide, we have got a summit data, which is going to be coming soon, and we don't have a renal data for the tirzepatide. Hemoglobin A1C reduction is same thing around 2% or roughly 2.2%. That is equal. Side effect profile, it was thought to be better with tirzepatide, as it is predominantly a GIP than the GLP-1. But if you see the table of the two, comparing the side effect profile, it is same. So GIP, it was supposed to have a lesser side effect, as it has got an inhibitory effect on the chemoreceptor trigger zone, which did not translate into the real side effect profile benefit. So what I will say, the potency wise, as far as weight reducing efficacy is concerned, the equivalent dosage and the maximum tolerated dosage, then it is almost same. Hemoglobin A1C reduction is same, but data are more robust with semaglutide at this given point of time than tirzepatide. Side effect profile is same. So almost semaglutide slightly
So your sum up is semaglutide is better?
Slightly.
Okay. Dr. Bipin?
No, semaglutide is not better if there are trials that have been done for weight reduction. I agree with Dr. Bansali that the body of evidence that we have in obese patients without diabetes for MACE reduction, for patients with diabetes for MACE reduction, for renal benefits, and the ESSENCE study and the STRIDE study for MASLD and peripheral vascular disease is available only with semaglutide. We have got evidences which are just coming up with tirzepatide, and it's like you and me to travel to, let's say, hopefully a destination. I come little bit later, you reach much earlier. So randomized controlled trials for these indications, we have got clear evidence and approval for semaglutide. But as if we are to believe that the actions are through GLP-1 agonism and most of them are mediated by weight, the likelihood of this is going to be more with tirzepatide. The trial with tirzepatide and dulaglutide in the CV outcome trial is about to come. I think it's called SURMOUNT or SURPASS. Evidences are yeah. So the evidences are being generated, but if one has to again go back to why it is being given. If the indication is something and for which indication the other molecule is not approved, I think it will be unfair. We can discuss with the patient that there is no data as yet with, let's say, tirzepatide for MASLD, for CVOT. But once that is published, then one can certainly say, and that's what happened with oral semaglutide. Till we had the result of SOUL, which are certainly inferior to that of Sustain 6 in terms of not having any protection. As a oral route of administration, we could not give that molecule to people who had a pre-existing atherosclerotic cardiovascular disease. Now we are able to give it. So I think as the data accumulates and accrues, which takes time for the molecule that has come again. Now we have retatrutide, which also is going to be, which is far more potent than anything. Then we have got drugs with IGF-1 along with it. So I guess this is something which is work in progress and only time will tell. But answering your question directly, that if a patient, for most people ask for cost constraints. And if they are asking for cost constraint, we can discuss with them that yes, this molecule which you are opting for, because higher dosages are not approved either by FDA or by our regulator for weight loss. So we cannot say that, for example, oral drugs also, we have a 25 milligram oral semaglutide, but that's not approved for use in our country. That produced 2.1% reduction in the in the
A1C.
HbA1c. So I guess one has to go by the indication, regulatory approval, but finally the patient decides, because it's out-of-pocket payment, and if the patient says that I will not be able to afford tirzepatide, and I'm happy with 66 or 70% of weight reduction, then so it be, the patient can go to 2.4 milligrams semaglutide more. So this will happen when the cost comes down. This I told you earlier. It happened with DP4, it happened with SGLT inhibitor, it happened with liraglutide, and it's bound to happen with all these molecules. But purely for weight loss, I will not be changing the patient from SEMA to from tirzepatide to SEMA.
Right. Would Dr. Triven Marwa have anything to add? Otherwise, we will wind up.
No, I think nicely concluded, but I also agree with Dr. Vipin Sethi that the person is already on this molecule and he's getting the results. Just merely for cost reason, I will not ask him to switch over. I would like to convince and explain then the value rather than the cost which is incurred by using this molecule, get good result to the given individual.
Right. Yeah. So I think we had a wonderful discussion, discussed threadbare, GLP-1 analogs, as well as dual and sometimes maybe referred to triple agonists, quadruple agonists. So it's a growing field and it's an exciting field. And hopefully we are able to provide the benefits of this class of drugs to wider number of patients. And it's welcome that we're getting this branded generics in our country, which are getting the molecules available to more number of patients. So we also need to gather our own experiences in terms of effects as well as side effects. Always the trial data do not translate into what we see with our own patients. So we have to keep our ears and our eyes open as well for any adverse effects that we may come across, maybe relatively new to our population rather than to others. But it's exciting, and I must thank our participants, audience from all across the country for keeping us busy with so many questions in the chat box and with an excellent faculty. I thank all of you, Dr. Anil Bansali, Dr. Bipin Sethi, Dr. Tiven Marwa, and of course also Dr. Narendra Kotwal for being such a wonderful resource person for this evening's program. Thanks all of you. And finally, of course, Intas too, for keeping up the tempo and really getting so many people to attend this program month after month. Thanks, and over to the organizers.
Thank you, sir. Thank you, Subhankar sir, for your valuable time. And I would also like to take this opportunity to thank you, our esteemed faculty, Dr. Bipin Sethi, sir, Dr. P.N. Marwa, sir, Dr. Bansali, sir. Thanks a lot for doing
Can I just interrupt? I just had this message from Dr. Pratik. I didn't notice earlier that we had today almost 2,000 attendees, 1,900 plus attendees, which is really good, shows the interest of our physician population. and of course, the attraction that this august faculty bears for everyone. Yes, sorry. Back to you, Brijesh.
Yes, sir. Thank you, sir. Thank you. So I was saying we had a very good discussion on GLP-1 analog. So I think the audience would, in coming months, when semaglutide will also coming up with the branded generics, so the audience will obviously will get the benefits out of this discussion. So once again, looking forward to doing so many programs like this. Thank you, sir.
Thank you. Very good night, all of
Thank
you.
you.
Good night, sir.
Thank
Good to
you.
meet you.
Thank you. Good night. Thank you.
Bye.
Thank you. Good night,
Thank you,
sir.
sir. Good night.
Thank you.
Good night.
Thank you, sir. It is always a pleasure
Sir,
to.
we are now offline.
Okay. Thank you, Rohan.